Well, I'm going to talk today about maternotoxic zones, a term I coined to help us all understand and really to frame differently what some other folk might call social determinants of health. So let's get started. This terminology came up when I struggled to really just agree, I think, with the fact that social determinants of health became a very new and, even to some exciting term that would help us suddenly understand where poor maternal health outcomes were coming from and why. And while I think it does give us some ideas, it helps point in the direction. Really what we might want to name them are structural determinants of health or historical determinants of health, meaning that these poor neighborhoods, low income neighborhoods, environments that are unhealthy or toxic, lack of green spaces, food deserts, all of this newish terminology that we now use to describe social determinants of health don't ever really clearly point us in the direction of understanding how they came to be. So of course, we all know they exist. We know that certain zip codes have higher propensity for these poor outcomes, perinatal outcomes, maternal health outcomes, infant health outcomes. Yes, we know that. And we say, well, it's because housing is dilapidated. There's violence, there's crime, there's stress. There are no resources. So that's the answer. This is why we have poor outcomes, because people who are existing in areas such as these, who are suffering under these social determinants of health, that's the answer as to why they have poor health. So yes and no. I believe we really need to encourage ourselves to think wider than that, and also to take responsibility more than that, because making those statements, putting those labels, determining which areas or zip codes are having these struggles, and then saying that's the cause is really disingenuous. So the reason these neighborhoods are like this is on purpose. These late neighborhoods and areas are like this because policy allows structural racism, the classism that exists in the United States, the ability to disenfranchise folk and to keep them disenfranchised, the condoning of certain folk need to live in certain areas or are banned from other areas, gentrification, all of these social practices, political practices, and policies are in place for a reason, and they actually work. And so there may be a nod towards, well, we don't technically do redlining, for example, anymore. Redlining is where, as housing developments grew, certain housing developments were banned. Black people or people of color were banned from, living there, where the realtors and the governments would not allow or, support people of color moving into those areas, into those houses, into those neighborhoods. So this is not by accident, this is by design. So even if we put, for example, we have the Civil Rights Act now, or this is actually, enacted into policy, but really at the end of the day, how much is it adhered to? How true is it that we are living in equitable ways and times? So voter disenfranchisement, for example, all of these things are all part of the same issue, but all of these things impact reproductive health. Okay, so I consider the maternotoxic zone to be anywhere where a mother-baby family, parent is trying to thrive and not able to do it because of the environment. And so in this case, yes, I'm going to agree that social determinants of health, all of those lists, places where you live, work, play, worship, those areas where they are not the best, those, yes, definitely are maternotoxic. They are not safe for a pregnant mother, a breastfeeding person, parenting, it's just not safe. Okay, so the toxicity though is in the actual environment. The toxicity is in the building. The toxicity is in the people who are maybe abusing drugs, or are, involved in crime, or, perpetrating domestic violence, right? The toxicity is there in the physical. So I also want to talk about the toxicity that's not in the physical, the toxicity that this zone, this area, the pop-up toxicity, where suddenly the person is receiving a different and inequitable way of being treated, because now the toxicity has popped up around this person, around her, that's saying, because of who you are, or who I think you are, your treatment is going to be this way. So there's the individual who might perpetrate some bias and some prejudice, some different way of treatment, different plan, lack of listening, lack of respect, lack of supporting dignity. That person is personally mediating the response. So the toxicity pops up because of the person's reaction to the patient or the woman. The other type of the pop-up toxicity is that inside of environments that should be safe, for example, the hospital, the Materno toxic zone just poof appears around this person, again in response to who she is, how she looks. So individual judgment and individual bias will impact her, and the Materno toxicity manifests, but structurally, institutionally, the toxicity is also built in. So deep inside a place of safety, there is also structural toxicity that exists. So the toxicity of implicit and explicit bias, racism, classism, sexism, is created wherever a pregnant woman of color may be. And it's not always going to be specific to a geographic. So do you see the difference between the physical social determinants of health, the neighborhood, etc., and the actual, it will travel and find you wherever you are. And that is why it's detrimental. So let's just sort of flip that and add the baby in. We talk about the mother-baby pair. And then, of course, the child, especially up to the first year of life, where unfortunately, yet again, Black and low-income Indigenous folk, their infant mortality rates are way higher. The baby may not make it through its first year of life. So Kimberly Seals-Allers, a great friend and colleague of mine who talks a lot and teaches about lactation, writes about lactation, she coined the phrase first food desert. So similarly, we know what a food desert is as far as adults, but for a newborn, for a mother who is attempting to breastfeed, there is lack of resources or a dearth of resources for her support, whether it's there isn't a baby-friendly hospital anywhere near her, or if there is, the baby-friendly hospital still has the toxicity embedded because of structural and institutional ways of being. There's no fresh fruit and vegetables for her in her area where she lives. There's no supporters, lactation counselors, lactation consultants, educators. There's a negativity and a lack of maybe familial support, generational tropes and ideas about why breastfeeding isn't the right thing to do. All of these things contribute to now, for the baby's sake, this is a first food desert. Do you see? So we are trying to really coin phrases and be creative around re-languaging, reframing this problem so we can understand it differently and better. You may be familiar with the work of Professor Saras Vedam out of British Columbia, a nurse midwife and leading the Birthplace Lab, and they have done numerous studies on listening to voices of mothers, listening to women of color. And this work is particularly important that they have now got quantitative as well as qualitative data that proves that people of color experience more mistreatment in birth, that 1 in 6 women in general experience mistreatment, 1 in 6 in the United States. But again, people of color disproportionately so. But the mistreatment being shouted at or scolded by healthcare providers, it being ignored by healthcare providers, failing to respond for help. Just ridiculous and outrageous, egregious behavior. Top 4 types of mistreatment: shouting, refusing help, violation of physical privacy, threatening to withhold treatment. This is what's going on, and this is what's now captured through their research. So ask yourself, what does quality care look like? What does safe care look like? Oh, it must be the building. It must be the equipment. Look at how fancy this hospital is. Look at all the technology. Oh, wow, it's amazing. The practitioners are magnet level, master's degree, physicians, perinatal, you name it. All of that stuff sounds good, looks good, but does it equate safety? Does it equate quality? Because the evidence isn't showing us that it does for certain people and the people that we care about. And of course, I think you will agree with me, especially if you're already interested in doing this training and becoming accredited through our work. You know, it's about the will to provide quality and safe care rather than these other pieces. So just to reiterate then, the JJ Ware, this maternal child healthcare system, is really looking at the other way of addressing these ills, which is creating a culture, creating an environment every time in every place. So that's whether it's in the community itself, whether it's in the physical office, whether it's in the hospital, whether it's in the birthing center, whether it's at home, wherever it is that we provide care, support, and services, that we create this bubble, if you will, of safety and quality around mother baby family, such that we make a difference. And of course, we have the stats to prove we make a difference. And that's important. So don't forget, the overarching fundamental premise is that every woman wants a healthy baby and every woman deserves one. And in our work to support that, to get to that full-term chunky baby, that experience that every mother deserves, and the parenting start that we all should have access to, we need to consider that do not contribute to being part of the maternotoxic zones.